Hi everyone, in this video I'll be discussing another topic, general anesthesia. So anesthesia means loss of sensations. General anesthesia means loss of sensation throughout the body. The whole body is anesthetized. In contrast, we have something called local anesthesia where the local area of the body is anesthetized. We usually do general anesthesia for major surgeries. Now in general anesthesia, there is reversible loss of almost all the sensations. It's not irreversible. If it is irreversible, patient will not get up only, he will die. So general anesthesia meaning is it's a reversible loss of. So remember, it's a reversible phenomenon. So it's a reversible phenomenon. There is reversible loss of consciousness. Okay, and sedation. Patient will be sleeping, and patient will have amnesia. He will have loss of memory for brief period, and he will have very good analgesia because during surgery pain should not be there, and patient should not be moving, so he should be immobile. How to make the person immobile? By causing muscle relaxation. So muscle should be relaxed. Suppose during surgery he keeps on shaking like this, it's difficult to do surgery. And the reflexes should also decrease. There is decrease in reflex, so the autonomic and somatic reflex should also decrease. So remember, it's a reversible phenomenon. Again, the person will regain them back. If he doesn't regain, he will die. So once we know what is the meaning of general anesthesia, what is the use? Where do you use general anesthesia? Where do you want to anesthetize somebody? Number one, usually we use it in surgeries, that too in major surgeries. Second, when you are giving electroconvulsive therapy, when you are giving an electric shock, we give anesthesia, that is general anesthesia. Number three, in a condition called status epilepticus. Status epilepticus, we can use it. Usually for status epilepticus, we use the anti-epileptic drugs, but still it is not controlled. The last resort will be general anesthesia. So that is the uses of general anesthetics. Now, once you know that, what are the drugs? What are the drugs used as general anesthetics? What are the drugs used? Now, the drugs can be classified like this. The drugs which are given through inhalation. So, anesthetics are inhaled and they go through the lungs and go to the brain. Second, they are given intravenous, IV drugs. Inhalation, we have two types. Either they are given as gas, for example, nitrous oxide, then a rare gas called xenon or cyclopropane. So cyclopropane. Then we have something called volatile liquids. Volatile liquids means they are stored in cylinders, but when they come out, they become gaseous. They are liquid, LPG gas. So liquid petroleum gas, it will be liquid, and when it comes, it will become gas. So they are called volatile. The main important thing is ether. One of the oldest one is ether, then halothane. So halothane. Then we have the DICE drugs. What is that DICE drug? DICE drugs, desflurane, isoflurane, sevoflurane, and enflurane. So they all end with fluorine drugs. So coming to the IV, in IV we have two important aspects. The faster acting ones, faster acting general anesthetics. What are these? The faster acting are the thiopentone sodium, thiopentone. Then we have a drug called propofol, and one more drug called etomidate. It is called as etomidate. Then we have the drugs which are given IV, but they are slower acting. They induce slower. So what are these drugs? In slower acting, we have the benzodiazepines, then opioids, and a drug called ketamine. So these are the intravenous drugs. So we can give drugs for anesthesia in two ways, either by inhalation or by intravenous. Benzodiazepines, opioids, thiopentone, we have already discussed in CNS topic. We need to discuss in detail the inhaled anesthetics. Let us start our journey. Now, to understand general anesthesia, let us understand that a patient has to undergo a surgery, that is hernia surgery. So patient has to be posted for hernia surgery. Then what will the anesthetist do? First of all, before surgery, before giving anesthesia, we give certain medications called pre-anesthetic medications. So we give pre-anesthetic medications. Now, why should we give pre-anesthetic medications? That's the question. The reason is, number one, patient will be anxious. Tomorrow there is surgery. Obviously, will be anxious. So, to decrease anxiety and also to cause anterograde amnesia, we use certain drugs called benzodiazepines. So they decrease the anxiety as well as anterograde amnesia. Anterograde amnesia means the patient should not remember the surgical events, whatever happened in anesthesia and all those things. So that is very good with benzodiazepines. They will cause anterograde amnesia. That means after giving the drug, whatever happens, patient will forget. The next important thing is to decrease secretions. Now, the secretions like the lung secretions, the gastric secretions, right? And the salivary secretion, what happens? They can go to the lung and they can cause aspiration in the lung. So, the drug which is used to decrease secretions the name is called glycopyrrolate. So, glycopyrrolate is used to decrease secretions. Not only that, to decrease reflex vagal bradycardia. Now, what happens during surgery? Many a times the vagus can get activated and the heart rate may come down. And glycopyrrolate is an anticholinergic drug which can increase the heart rate. So, the advantage of this is it doesn't cross blood-brain barrier, but other drugs can cause. Atropine can cause, so we don't give atropine before surgery because it causes delirium confusions. Another important is you decrease the HCl secretions. To decrease HCl secretion, we can give the H2 blockers like ranitidine, or we can give proton pump inhibitors like pantoprazole, like that. Certain times they are also adding antiemetics can be given like ondansetron, metoclopramide, domperidone, they can be used. And opioid analgesics are also given before surgery. So these are all the medications given before surgery because we have to decrease anxiety, we have to cause anterograde amnesia. So the best drugs are benzodiazepines, decrease secretions and reflex bradycardia, glycopyrrolate, decrease HCl, antiemetics and opioid analgesics should be given. Now once the patient is ready, then we start the anesthesia. So that is called induction. So when the patient is ready for surgery, anesthesia has to be started. That is called induction of anesthesia. Induction meaning is to start. So once it is started, now the anesthesia has to be maintained. Maintain anesthesia. So until what time we should maintain the anesthesia? Until the surgery is done. So surgery is done. Until that you have to maintain the anesthesia. Now once the surgery is over, the hernia surgery is over, then the surgeon will tell anesthetist to stop it because the surgery is over. So then the anesthesia is stopped. So once the anesthesia is stopped, then the patient will go for recovery. So he has to recover, and that is what we told you. Reversible loss. So all those should come. Consciousness should come, the reflexes should come, muscle should come back to the actions. So all these things, what is done during anesthesia, pre-anesthetic medication, induction, maintenance, surgery is over, stop the anesthesia, and the patient will recover, what we see in post-operative wards. Once we have understood the procedure, let us understand the mechanism of action of these drugs. Mechanism of action of the general anesthetics. So obviously, if you want to anesthetize, you want to stop the CNS, you have to suppress the CNS. So most of them should suppress the CNS. So what is their mechanism of action? Most of the inhaled general anesthetics, they will increase the activity of GABA. So they increase GABA activity. So that is one thing. And also they act as one more inhibitory neurotransmitter, glycine. They also act as glycine agonist. You know that the major inhibitory neurotransmitter in the brain is GABA, so increase it. The major inhibitory neurotransmitter in spinal cord is glycine, increase that activity. So when you increase this, there is CNS depression. So there is CNS depression. And they have also shown to produce potassium channel opening. So we have learned the same concept in anesthesia. We have learned the same concept in epilepsy also. We open the potassium channels there. Now other drugs like ketamine and nitrous oxide, they have additional mechanism of action. What is that? They decrease the activity of glutamate. Now you know that glutamate is excitatory and one of the receptor is NMDA. So these are NMDA antagonist. So ketamine and N2O, nitrous oxide, they have a special property. So now we are in a position to understand the mechanism. Let us understand the specialties of inhaled general anesthetics. Inhaled general anesthetics. Now, when we have the inhaled general anesthetics, obviously the patient has to inhale it through the nose or mouth, mainly from the mouth. So the drug has to enter the lungs. From the lungs, it goes to the brain and it produces the actions. So how to deliver it? Inhaled anesthetics, how to deliver it? Techniques of inhalation. Techniques of inhalation. Now, earlier there was a technique called open drop method. The open drop method is not followed nowadays. The nurse used to sit by the side of the patient, then put a kerchief and put a drop by drop anesthesia. So from that the patient used to inhale. That is not practiced now. Nowadays we have anesthetic machines. Anesthetic machines like Boyle's machine, and there are two ways to deliver the anesthetic. One is called the open system and one more is called the closed system. Sir, what do you mean by open system and closed system? The meaning is, in open system, patient will inhale the anesthetic and exhale it, so it will go out. In closed system, patient will inhale the anesthetic and he will exhale it, and again that exhale is rebreathed again. So it is rebreathed again. The carbon dioxide is absorbed using soda lime. There is something called carbon dioxide. When we exhale, carbon dioxide will also come, that will be absorbed by soda lime, and remaining anesthetics again will go back. So like this we conserve general anesthesia. The drug can be conserved. So we take the anesthetic, we exhale the anesthetic, again that can be reabsorbed back. That is called the closed system. But in open system, we inhale the anesthetic, exhale it, it will go out, we will not inhale it again. So that is the meaning of open system. Remember, these are supplied in cylinders and their cylinders have different colors. And there is one more thing called pin index. So pin index is very important. When you take the cylinder and you want to fit that in Boyle's machine, the pin index should match. If it doesn't match, the cylinder will not fit. So this is done to avoid the miscommunication, to avoid the barotrauma. What happens is, when we are giving the cylinders, the pressure is different in different cylinders. Now if you give so much of high pressure to the lungs may rupture. That's the reason the cylinder should be identified with the color. Even if it is identified with the color, it should fit with the same pin. Then you will have the correct pressure and the patient will not have any barotrauma to the lungs. So to avoid the mistakes, we have pin index as well as color coding for the cylinders that will be taught in anesthesia. So that is about the techniques. Stages. So when we give the anesthesia, there are stages of general anesthesia. The first stage. So stages. The first stage is called stage of analgesia. The pain comes down. Then the second stage is stage of delirium, that is confusion. The third stage is stage of surgical anesthesia. Now this is the stage where the surgery is performed, but when you are performing the surgery, the anesthetist will maintain the airway, you will maintain the breathing, and he will be monitoring the circulation. So when you enter the OT, you will see the pulse rate, the BP, everything is monitored. Now, many a times the patient will be put on ventilator also, and that has to be monitored. So the anesthetist will do that. Now, if you still continue giving anesthesia, patient will go for stage of medullary paralysis, and if you still give, patient may die. But we don't go to that stages. We give the drug within this. So once the surgery is done, we stop the anesthesia and the patient will come back. But if you give the anesthesia more and more in depth, patient will go for medullary paralysis and death. So we don't go for that. We will stay up to stage 3. Now all these stages are demonstrated by a older anesthetic, that is ether. Otherwise, we don't differentiate these stages in anesthesia. Only in ether we can see all the stages. Otherwise, in other anesthetics, these are overlapped. You cannot identify when is analgesia, when is delirium, when the patient go for a surgical anesthesia. So that is seen only with ether. And whenever we think of inhaled general anesthetics, it is important we understand the pharmacokinetics of them. Okay, so let us understand the pharmacokinetics of inhaled general anesthetics. Inhaled general anesthetics. So it's a very good correlation between your general pharmacology. Now, we know that pharmacokinetics means absorption, distribution, metabolism, and excretion part. Now, how do you give anesthetics? We give it through inhalation route. So let us trace what happens here. Let us trace. So let me draw. So this is the person, and we give the anesthetics by inhalation route. So from here it will go and reaches the lung. So there is bifurcation here. And this is the lung here. Yes. So let me draw the bifurcations like this. So here, like this. So when the general anesthetics is inhaled, it will come to the lung and it will reach the alveoli. So that is a place where the exchange occurs. So let us understand what happens in the alveoli, that is a terminal part. To understand that, let me draw the alveoli in a big manner. So this is the alveoli, clear? And this is the blood vessel. So this is the blood vessel. Yes. Now let me take the example of nitrous oxide, N2O. Now it's a gas. Now when we give a gas, we give it with partial pressure. So the gases are given with partial pressure. So they are given with pressure. So we cannot give it too high pressure. That's why I told you there are separate cylinders and they deliver the gases with high pressure. So to avoid the high pressure, we have a machine called Boyle's machine, which will cut down that high pressure and give the normal pressure. Now, please tell me, if you give it with high pressure, not so high, will the induction be faster? Induction means anesthesia will be faster or slower? Yes, obviously, it's like giving the drug in high concentration. So if the partial pressure is high, obviously the induction of anesthesia is faster. That means if you give the drug at high dose, obviously it will work faster. And if the pressure is low, the induction will be slower. So that is point number 1. So if the partial pressure, so when the person inhales, along with oxygen, he also inhales nitrous oxide. If the partial pressure of nitrous oxide is more, obviously the induction is faster. If it is low, the induction is slower. But the pressure should not be too high so that the alveolar rupture, right? The second important thing is ventilation process. So what is ventilation? Suppose the patient is having ventilation, inhale, exhale. So if he is doing more ventilation, obviously the drug will act faster. If he is not breathing only, the drug will act slower. So the point is, if the ventilation is fast, then the induction is also faster. If the ventilation is slower, the induction is also slower. It's a common understanding, no need to worry for that. If they breathe, then more and more drug will enter. If they don't breathe, they breathe very slowly, what happens? So it will not be induced faster. Number 3, there is something called alveolar exchange. So alveolar exchange. So nitrous oxide has to come here and it has to move into the blood vessel. So this exchange should happen. That will happen only if the alveoli are healthy. If they are fibrosed, if they are damaged, the nitrous oxide cannot enter. So if there is damage, then the induction will be slower. Correct. Now this is very, very important. Now when we give nitrous oxide is a gas. Now this is the blood. Now what happens? Some of the gases, they will dissolve in the blood. They will dissolve in the blood. Now when they dissolve in the blood, some are dissolved, some are free. What do you mean by dissolve? They enter the blood. Free means they don't enter the blood. So the free one and the dissolved one will come. Now they will come to the part where from the lungs they will go to the heart. From the heart they will reach the brain. So what happens in the brain? This is the brain. Now when they reach the brain, remember the free one is easy to go. So the free one is free to go inside because it's free. The one which is dissolved in the blood has to become free and then enter. So it is like if you compare the general pharmacology, we had a bound drug and a free drug. Now who is easy to enter? Distribute. Free drug. Bound drug has to become free and then it will enter. So it takes time. So if a drug is dissolved, it takes time to induce. If it is more in the free form, it is easy to induce. So for that we have a parameter that is called blood gas coefficient. Blood gas coefficient. So this coefficient will tell us how much is dissolved in the blood, how much is in the gas form, that is free form. If this coefficient is more, what do you mean by that? If blood gas coefficient, I'll take an example. If the blood gas coefficient of nitrous oxide is 0.47, what do you mean by that? Let me tell you the blood gas coefficient of another drug. Its name is halothane. Halothane has a blood gas coefficient of 2.3. What do you mean by that? The meaning is if this coefficient is low, that means drug is less dissolved, more free form. If this coefficient is more, that means drug is more dissolved and less in the free form. Remember, this will tell us how much is dissolved and how much is in free form. A free gas will induce faster. So let me write like this. Blood gas coefficient is inversely proportional to induction. Is inversely proportional to induction. This is very, very important. For example, nitrous oxide has a value of 0.47. What happens to the induction? This value is low. So it will have faster induction. Why faster induction, sir? Reason is less is dissolved, more is free form. Now this halothane has slow induction. The reason is more is dissolved in the blood and less is available in the free form. That's the reason I told you blood gas coefficient will tell us the rate of induction. If the values are more, induction is slower. If the value is less, induction is faster. That's why nitrous oxide has faster induction, halothane has slower induction. We can compare with this with an example. You take a glass of water, take the salt and dissolve it. Take the salt and dissolve it. And I want a salt back. You have dissolved it. What you will do? You have to keep it in the sun. The water will evaporate and then you will get a salt. So it takes time. Same thing here. If the gas dissolves in the blood, it has dissolved. Again, it has to work, means it has to come out from the blood and go to the brain. So it takes time. You take the example of a sand. Take a cup or take a glass of water, put the sand inside and it will not dissolve. Sand will not dissolve. So I want the sand back. What you will do? You will just take a cloth and pour the water. The water will go, the sand will remain in the cloth. So it's easy. So that's why the blood gas coefficient will tell us in simple words the induction. If the values are lesser, it is faster induction. If the values are more, slower induction. That means. So blood means how much is dissolved, gas means how much is free. That's it. No need to worry for that. So you can write like this, blood gas. So if the value is 2.3, blood gas, if the value is 0.47. So higher the value, slow induction, lower the value, faster induction, that's it. So that is about how the drug is absorbed and how the drug enters the brain. Now another parameter we need to discuss here in the pharmacokinetics of inhaled anesthetic. So one other parameter we need to discuss in inhaled anesthetics is a concept called distribution. A concept called distribution. So what do you mean by distribution? Now let me take the example here. So this is the blood vessel. Now when we give general anesthesia, for example, nitrous oxide will enter the brain faster. Why it will enter the brain faster? Because the brain has more blood flow. It can also enter the liver. It can also enter the kidneys. But it can also enter a tissue called adipose tissue. Adipose tissues. It can also enter the skeletal muscle. You have studied that in general pharma also. So the distribution occurs. So mainly the supply is for the brain because more blood flow, liver, then kidney, and it will go slowly to the skeletal muscle, very slowly to the adipose tissue because the blood flow is less. Now once the action is over, again the drugs have to come back. So they have to come back from the brain again. They have to come back from the brain, liver, kidney again. From skeletal muscle it takes time. From the adipose tissue it takes time because the blood flow is less, it will not go out. Now remember, if it stays in the adipose tissue, this is called tissue binding. So if it is binding to the tissues like adipose tissue, it takes time. Now problem is, if it is staying in the blood, if it is staying in the tissues for a very long time, after we stop the anesthesia, will the patient recover faster? No, it takes time. Suppose still the drug is still in the adipose tissue, it is not coming out. Will the patient recover faster? No, he will not recover faster. So that phenomenon is given by a coefficient called oil gas coefficient. Oil gas coefficient. Oil means how much is dissolved in the adipose tissue. Gas means how much is in the free form. Now remember, if they are bind to adipose tissue, they are not going to come out. Only the free form will go out. Right? So the oil gas coefficient will tell us time to recovery. Time to recovery from general anesthesia. It will tell us the time to recovery. So for example, oil gas coefficient is inversely proportional to recovery. It is inversely proportional to recovery. Very, very important point. So if the values are more, it takes longer time to recover. If the values are less, it takes lesser time to recover. So that is the meaning of oil gas coefficient. Clear? So once we are done with that, let us understand one more concept called minimum alveolar concentration. Minimum alveolar concentration. So it is called as MAC value, MAC. It is nothing but it's the lowest concentration of general anesthesia required to be present in alveoli. Lowest concentration of general anesthesia required to be present in alveoli, which produces immobility, in 50% of population. 50% of population, that is called MAC. So MAC sounds like the EC50 in general pharmacology or the ED50 in general pharmacology. So to produce immobility in 50% of population, what is the minimum quantity required? That is called EC50. Remember, MAC is inversely proportional to potency. MAC is inversely proportional to potency. That means if MAC values are high, potency is low. So that is the meaning. Same thing we have discussed, the effective dose 50. So effective dose means potency. Yes or no? So dose is inversely proportional to potency. Higher the dose, less is the potency. So MAC is nothing but, MAC is telling you the drug concentration, that is the dose. So let us take an example. Nitrous oxide has a MAC value of 105. And one more drug I will tell you, the name is methoxyfluorine. Methoxyfluorine, the MAC value is 0.16. Now you pause the video and tell me among A and B, which is more potent? Which is more potent? The MAC value, that is minimum alveolar concentration for nitrous oxide, is 105%. Methoxyfluorine is 0.16. Now tell me who is more potent. Obviously, the one which is used at low dose, this is more potent. And the one which is used at high dose, this is least potent. This is least potent. So these are the comparisons what we have. Okay, so these are the comparisons. Let me summarize the things. Now, blood gas coefficient is repeatedly asked. Blood gas coefficient tells us how much is dissolved in the blood and how much is in the free form, that is gas. Now, if it is dissolved more in the blood, the coefficient is going to increase. Now, remember, blood gas coefficient is inversely proportional to induction. If the value is low, induction is faster. If the value is high, the induction is slower. Simple. Oil gas coefficient will tell us how much is bound to tissues. If the drug is more bound to tissue and less free form, that means it takes more time for the patient to recover. So oil gas coefficient will tell us the recovery. They are inversely proportional. If the oil gas coefficient is high, time for recovery decreases. If this coefficient is low, time to recovery increases. So patient will recover faster. One more is MAC, minimum alveolar concentration. Lower the value, the drug is more potent. Higher the value, the drug is less potent. That's it. Okay, now what I will do is I will show you a chart. You pause the video and try to answer these questions. Okay, so this is the chart. You can see here. I have given the MAC value. I have given the oil gas coefficient. I have given blood gas coefficient. Now pause the video and tell me which one will have more potency, which one will take more time to recover, and which one will induce faster. Take your time and answer. Pause the video and answer this. Yes, so let us analyze this. MAC value, I told you, minimum alveolar concentration is inversely proportional to potency, correct? Now, which one has highest value? You can see nitrous oxide. So nitrous oxide has 105. So it is the it has the value of 105. It is the least potent one. Least potent. Now what will have lowest? 7 to 1.9, 1.7, 1.2, 0.75. The least one is 0.16, that is methoxyfluorine. It is the least MAC value, so the drug is most potent. You all agree for that? Yes. So next parameter you need to analyze is oil gas coefficient. I told you oil gas coefficient is inversely proportional to recovery. That means if the levels are low, then the recovery is faster. If the levels are more, the recovery is slower. So analyze this coefficient. So 1.4, 19, 53, 65, 98, 98, 225, 825. So the oil gas coefficient is more with methoxyfluorine. That means methoxyfluorine goes to the tissues and binds there for a very long period. So the recovery takes time. So more the value, it will be slow recovery. Recovery will be slower. Now remember, the oil gas coefficient for nitrous oxide is very low, 1.4. So the patient will have fast recovery from the anesthesia. That's the meaning of that. Coming to the blood gas coefficient. Now you know that blood gas coefficient is going to tell us the induction. So it is inversely proportional to induction. Inversely proportional to induction, correct? Yes. So what is the minimum value you have? Minimum value is 0.42, we have marked it. Now this will cause fast induction. Fast induction. So it will induce faster. Now tell me which one has highest value here. 0.47, 0.63, 12, 1.9, 1.4, 2.3, and the highest will be 13. Now this will take time to induce slow. It will have slow induction. It takes so much of time for induction, that is methoxyfluorine. Now why methoxyfluorine is not used nowadays? Because it is highly nephrotoxic, and because it binds to the tissues for a very long period, it can cause toxicity. So that is the meaning of the values MAC, oil gas, and blood gas coefficient. Remember, MAC is inversely proportional to potency. Oil gas coefficient is inversely proportional to recovery. And blood gas coefficient is inversely proportional to induction. And we have demonstrated that in the table. So that is the understanding here. Clear? So these are the parameters we need to discuss. So we understood the pharmacokinetics, that is absorption, distribution, and what about the metabolism of these drugs? What about the metabolism of general anesthetics? These general anesthetics are no or minimal metabolism. They are not undergoing any metabolism. That is the reason I told you there is a system called closed system where the patient exhales the anesthetic and he again inhales that. So the drug is not metabolized, so you are getting the drug again. Now there is only one drug which can undergo metabolism, that is called halothane. Even halothane can undergo 20% hepatic metabolism. 20% hepatic metabolism is seen with the drug halothane. Now moving on to the elimination, where do you throw these drugs out? Elimination is again through the lungs. So where they entered, they will come out through that only, not through the urine or through the bile, through the lungs by exhaled air. And removal is in reverse order. What do you mean by reverse order? So they enter the brain. From the brain, they again come to the blood vessel. From blood vessel, they come to the lung, alveoli, then trachea, then mouth or nose, they will come out. So that is the meaning of elimination. Right? So these are the things. Now, once we understand the pharmacokinetics, let us understand the individual drugs here. So individual drugs in case of inhaled general anesthetic. So whenever we think of individual drugs, think whether they have very good analgesic property, anesthetic property, whether they relax the muscle, are they safe, are there any contraindications, do they cause any irritation in the throat when we are inducing, do they cause any irritation in the respiratory tract, are they causing any emetic action, can we use cautery, or is this safe in asthma patients? Now, some of the important points what is required for you will be discussing. The first drug is nitrous oxide. The first drug is nitrous oxide. Whenever we think of nitrous oxide, there are two things they are asking in the exam. One is called the second gas effect, and one more is diffusion hypoxia. One is called the second gas effect, one is diffusion hypoxia. Now, what do you mean by that second gas effect? Now, let me draw the lung here. This is the lung. So, this is the lung. Now, usually what we do is we use nitrous oxide with halothane. We use nitrous oxide with halothane for starting the anesthesia. Now, first what happens when we give nitrous oxide, it will enter. Now, what happens when it enters? This is the alveoli. Let me draw the alveoli. This is the alveoli. This is the blood vessel. Now, when we give nitrous oxide will occupy lot of spaces in the alveoli. So, it will occupy lot of spaces. So, nitrous oxide is full everywhere. Now, what happens? Suddenly, it will diffuse into the blood vessel. So, suddenly it enters inside. Now, what happens when it suddenly enters inside? There is a vacuum created inside. There is a vacuum created. You know, if this is a beaker and we use a pipette, a glass pipette with a rubber tubing like this. Now, when we push that tubing like this, the water will come up. Why? Because you have created negative pressure. So, the water goes up like this through the pipette. Similarly, when you suddenly remove the nitrous oxide from the alveoli, you create a negative pressure. When you create a negative pressure, if you are giving one more drug like halothane along with that, the halothane can also come back and enter into the alveoli. So this is what we mean by the second gas effect. This is because of nitrous oxide, only seen with nitrous oxide because it can occupy the alveoli more compared to other gases, it can occupy the alveoli completely. So when it diffuses faster inside, it will create a negative pressure and draws halogen inside, and that effect is called second gas effect. So it will take that also easily. Another important aspect what we need to understand is a condition called diffusion hypoxia. Sir, what do you mean by diffusion hypoxia? This is seen when the patient is recovering from anesthesia. Now you may ask a question, sir, why only it is seen with nitrous oxide is a big question, because you know that the MAC value for nitrous oxide is 104. That means you are giving it at very high dose. So that's why I told you it can occupy the whole alveoli and suddenly it will diffuse into this. And the negative pressure is created by that. That's why the values are higher with that. And that's the reason only this nitrous oxide can do that second gas effect. Now, what happens? What do you mean by diffusion hypoxia? Now, once the surgery is over, you stop the nitrous oxide. What happens when you stop giving nitrous oxide? Now the nitrous oxide has to go out. So this is the alveoli and this is the blood vessel. This is the blood vessel. Now when you stop the nitrous oxide or anesthesia, I told you they are eliminated. So nitrous oxide will come out of the blood vessel and immediately occupy the alveoli. So I told you nitrous oxide can occupy the alveoli fully. So once nitrous oxide occupies the alveoli fully, where is the room for oxygen? Oxygen cannot enter. So patient will suffer with hypoxia, and when it is seen during diffusion of nitrous oxide back to the alveoli. So that is called diffusion hypoxia. So suddenly the nitrous oxide come back to the alveoli, there is no space for oxygen, patient will have hypoxia. So how to prevent this, sir? How to prevent this? Now the prevention is done like this. Before stopping nitrous oxide, what we should do is oxygen has given. So oxygen is given to stop diffusion hypoxia. So if you don't give oxygen to the patient, and only if you stop the nitrous oxide, it will occupy the alveoli, patient will go for hypoxia. So when you are stopping nitrous oxide, you have to give oxygen from outside. So this is how we prevent diffusion hypoxia. Remember, nitrous oxide asked for two effects, second gas effect, and one more is diffusion hypoxia. Okay, so let us understand the important advantages of nitrous oxide. So nitrous oxide is also called as laughing gas. The advantage is it's a very good analgesic. So it can relieve the pain. It's a very good analgesic. And remember, it is not inflammable. It will not inflame. It will not irritate the respiratory tract. And it is not costlier. It will not cause any MSS. It is non-toxic to the kidney and liver. And remember, it can produce second gas effect. What is the disadvantage? The disadvantage is, I told you have to analyze whether they produce good muscle relaxation. No, it's a poor muscle relaxant. It's a poor anesthetic. So it's a best analgesic, that's it. And it can produce diffusion hypoxia, and it can decrease B12 levels. And this is not seen in 1 day, 2 day. If you are using it for a very long period, then only. And it is avoided in air-filled spaces surgeries. For example, if you are doing a pneumothorax or middle ear surgeries, the chances of nitrous oxide entering into that and increasing the pressure inside the cavity is more. So avoid in that is air-filled spaces. So these are the disadvantages of nitrous oxide. Now moving on to another drug, the name is called halothane. The name is halothane. Halothane, let us discuss the advantages of halothane. The advantage of halothane is it's a very potent anesthetic. That means you require less MAC. It's a bronchodilator, so you can use it in bronchial asthma patient. Used in bronchial asthma patient, bronchodilator. And it can produce controlled hypotension. Controlled hypotension. And it's a very good uterine relaxant. The question is, will you give it in a pregnant woman or will you give it during delivery? So if you want to use this anesthetic, which patient is it ideal? Pregnant or delivery patient? Obviously pregnant it is given because it has uterine relaxant property. In delivery time, you avoid this. Why? Because in delivery time, you want the uterus to contract and deliver the baby. So during delivery, don't use halothane. But during pregnancies, you have to do some surgeries, you can give halothane because it's a uterine relaxant. Now, it is also used in children, can be used in children. Can be used in children. What is the disadvantage? Disadvantages of halothane. Now, number one, it's a poor analgesic. So, pain is not reduced. And muscle relaxant. And it's a myocardial suppressant, CVS suppressant. So that's what we have written. It is going to cause controlled hypotension. Certainly the BP may fall, the heart rate may decrease. But one important thing what they will ask in the exam is, it is contraindicated in pheochromocytoma surgery. This is the one which you have to highlight. Why pheochromocytoma? Because halothane sensitizes heart to adrenaline. So what happens if the heart is sensitized to adrenaline? This will cause arrhythmias. Now what is the problem in pheochromocytoma? Pheochromocytoma, already the adrenaline levels are high. If you give halothane, adrenaline is already high. It will work on the heart, increase the heart rate, and there is a risk of arrhythmia and patient may die. So don't give it in pheochromocytoma patient because it sensitizes the heart to adrenaline and there is a risk of arrhythmia. So contraindicated in pheochromocytoma surgery. And halothane, remember, for hepatitis. So it can cause hepatitis. 1 in 1,000 patients, if you administer 1 in 1,000 patients, it is seen. Another important problem what we see with that is it can produce malignant hyperthermia. So we have discussed this in pharmacogenetics. What do you mean by malignant hyperthermia? It's a pharmacogenetic condition. There is a problem with rhinodine receptor 1. The calcium is released more. The muscle will contract, temperature will go up. So what is the drug of choice for that? Drug of choice for that is dantrolene sodium. And what drugs are known to produce malignant hyperthermia? Inhaled anesthetics as well as succinylcholine can cause malignant hyperthermia. So these are the advantages and disadvantages of halothane. Now many times we combine halothane with nitrous oxide. Is there any advantage? Halothane with nitrous oxide, is there any advantage? You think and tell me. Now halothane is a very good anesthetic. It's a very good anesthetic, but a poor analgesic. But nitrous oxide is a poor anesthetic and a good analgesic. So that's the reason when we combine them, these will complement each other, and there is an effect called second gas effect. So the second gas effect will help halothane to drawn inside the lung, and halothane will also enter easily and cause anesthesia. So that is the advantage of combining halothane and nitrous oxide. It is a good anesthetic, it's a poor, so that will compensate. This is a poor analgesic, this is a good analgesic, that will compensate, and you see second gas effect. That's the advantage. Now moving on to the next one. The next one is the oldest one called ether. Now remember, ether is very pungent in odor. It is irritating vapor, so you cannot induce with that, and it is inflammable. You cannot use cautery. If you use cautery, there will be a blast. So it's highly irritating. Cautery cannot be used. It's highly inflammable. And you can see all the stages of anesthesia, that is called Goodell stages of anesthesia, stage 1, stage 2, stage 3, all. And it is one of the beautiful drug in unskilled hands also. So remember the importance of ether, but nowadays the usage is not that much. So it has a pungent odor. It is inflammable. So cautery not used during surgery, and it is irritant vapor, so it is irritant to the lungs. You cannot use it for induction, but it's a good muscle relaxant and analgesic. So that is about ether. Once we know about ether, let us understand the other drug, enflurane, the fluranes. Now remember, enflurane E, start with E. It is causing an adverse effect, seizures. Remember, E stands for E, epilepsy, seizures. Isoflurane, it has a pungent odor. Remember, if they have pungent odor, we don't use them for induction of anesthesia. We don't want the patient to inhale it in the beginning. They will have the cough reflex and all those things. Second, it maintains cardiovascular stability. Maintains cardiovascular stability. That means the parameters like BP, cardiac output, they don't alter so much with this drug. So that's why it is preferred in. The drug is preferred in a patient with cardiac problem. So preferred in cardiac patients, and also it is preferred in a patient with ISD. So it is safe in a cardiac patient and in ischemic heart disease patient. Now once you know isoflurane, let us understand something called desflurane. Now the name starts with D. D for it is preferred for daycare surgery. Now remember why it is preferred for daycare surgery. The reason is simple. The drug has fast induction and fast recovery. So what do you mean by daycare surgery? We admit a patient a day before or in the morning. We discharge the patient on the same day. So for that, the drug should work faster, and the patient also has to recover faster. Now remember again, desflurane irritates the respiratory tract, so it is also not used for induction. Then we have a drug by the name sevoflurane. Sevoflurane is used for induction and maintenance also. So others are used for maintenance. Now it is used for induction. It will not cause irritation of the respiratory tract. The odor is not so much pungent with this, no problem. And it is preferred in children. Smooth induction, so preferred in children. Now one important thing is it is not used in closed system. Now what do you understand by closed system? The meaning is simple. I told you earlier, we inhale the anesthetic, we exhale the same anesthetic drug. They don't undergo any metabolism, they come out as such. Now when you exhale them, along with that carbon dioxide will also come. When the carbon dioxide comes, to observe that we have soda lime. So again we inhale back the anesthetic again. So that is the closed system. But when you give sevoflurane when it comes, there is soda lime. It combines with soda lime and forms a toxic compound. And that compound is toxic to the kidneys. So that's why you don't use sevoflurane in closed system. So the problem is sevoflurane combines with soda lime and forms compound A. That is the name given to the toxic one, and it can cause nephrotoxicity. Nephrotoxicity, that is about the inhaled anesthetics. Now let us draw the conclusions for all these things. Conclusions. So what are the conclusions? Number one, I told you before you use this, check whether they are inflammable or not. So all are non-inflammable except, can you tell me? They will not explode. What is the one which explodes or inflammable? It is ether. Very good. Second general rule for general anesthesia, that is inhaled, all produce hypotension. All of them produce hypotension. Sir, what about sevoflurane, isoflurane? Isoflurane will also produce, but not that much. So it will maintain the cardiovascular stability. So all of them can produce hypotension. Number three, let me tell you here, all produce hypotension, all produce respiratory depression. Okay, all produce depression and they also cause muscle relaxation. Now, what will not cause muscle relaxation except nitrous oxide and halothane? They are not very good muscle relaxants. So, muscle relaxation exception is nitrous oxide and halothane. So, all of them produce respiratory depression. All of them produce muscle relaxation. The exception for muscle relaxation is nitrous oxide and halothane. Nitrous oxide and halothane can cause respiratory depression, but they can't cause muscle relaxation. We have discussed that point earlier. Number four, most of them are bronchodilators. Since they are irritant, we don't give it in asthma. Most of them are bronchodilators. Some are irritant, so we don't use it in asthma patients. Number five, no hepatotoxicity. They don't cause any hepatotoxicity. So tell me which is the one which causes hepatotoxicity, and that is called halothane. Except halothane, which can cause hepatitis, no other will cause hepatotoxicity. Only hepatitis is caused by halothane. All are used in closed system. All are used in closed system. Can you tell me exception? Except sevoflurane. Can you tell me the reason? Sevoflurane with soda lime produces compound A, which is nephrotoxin. Number 7, all can cause malignant hyperthermia. I told you inhaled anesthetics can cause malignant hyperthermia except nitrous oxide. So everything is been concluded here. Okay, so please go through this. Very, very important. Very, very important. So some of the preferred I will just write for you. Preferred. Suppose you are doing a surgery in cardiac patient. What is preferred is isoflurane, I told you, because it maintains the cardiovascular stability. Children, it is sevoflurane. Pregnancy, halothane. Pregnancy, halothane. And daycare surgery, it is called desflurane. Desflurane. Now the drug not used for induction, not used to start because they are having pungent odor or they are irritant. They are iso, des, and ether. So isoflurane, desflurane, ether, they are not used for induction of anesthesia. So all these are the important points regarding these inhaled general anesthetics. Okay. So once we know the common properties of the inhaled anesthetics, one more inhaled anesthetic is xenon. So when you see about xenon, xenon is a rare inert gas. So the meaning of inert gas means they don't react with others. They are available very rarely. So since they are available rarely, it is expensive. You cannot easily synthesize that in the lab. Now, as an anesthetic, what is the mechanism of action? The mechanism of action is it's an NMDA antagonist. It's an NMDA antagonist. Second, it also is a TRK channel agonist. So this is the mechanism of action of xenon. One more advantage of xenon is it has the fastest induction among all the inhaled anesthetics. Fastest induction, that means it has the lowest blood gas coefficient. And the drug also has fast recovery. So it is one of the beautiful anesthetic, but the problem is not easily available and it is expensive. So let us now discuss intravenous anesthetics. Let us start. Intravenous anesthetics. Usually intravenous anesthetics are used for induction of anesthesia, that means to start. In that, let us start with the drug. The name of the drug is thiopentone sodium. Thiopentone sodium, as the name suggests, it is already been discussed in barbiturate. It's one of the barbiturate drug. Now the drug is used for induction of anesthesia. Induction of anesthesia it is used. Right? And second, it is also used in a serum called truth serum, which is used for narcoanalysis. Can you tell me one more drug used in narcoanalysis along with thiopentone? You're right, hyoscine. Sometimes it is also used to treat status epilepticus. So these are the uses of thiopentone sodium apart from anesthesia. Pharmacokinetically, the drug is highly lipid soluble. Since it is highly lipid soluble, the advantage is the drug has faster onset of action. So it can enter the brain faster. Second important is the drug is ultra short acting. Thiopentone is ultra short acting. Suppose if I give this for induction, if I tell the patient to count 10, 9, 8, 7, within 10 seconds, patient will be in anesthesia. But after 10 minutes, the patient will again get back. The drug is shorter acting because of the phenomenon, redistribution phenomenon. So the drug is ultra short acting. So these are the importance about thiopentone sodium. And remember, this is supplied as highly alkaline solution. So when we use it, it is a highly alkaline solution. And when we give IV, no problem. But when you give it accidentally into the artery, accidental arterial injection, what happens? When it is injected into the artery, there is a chance of the drug getting precipitated. Patient may have ischemia and gangrene. So this is the problem. When you accidentally give it, it can cause ischemia and gangrene. Now it's a very good anesthetic, but it doesn't have any analgesic property, and it's a very poor muscle relaxant. It's mainly used for induction of anesthesia. So that is about the drug thiopentone. Sodium, remember, it is highly alkaline solution. And we have discussed about barbiturates already in the CNS, that is benzodiazepines and barbiturates. Now moving on to the second drug, the group of drugs we are going to discuss are benzodiazepines. Benzodiazepines which are commonly used are midazolam, then lorazepam, and diazepam. Now, what is the advantage of them in anesthesia? Number one, they are used as pre-anesthetic medication. I told you they can decrease the anxiety. They are used as pre-anesthetic medication. Before anesthesia also we can use them. The advantage is they decrease the anxiety and they can produce anterograde amnesia. Anterograde amnesia. And in anesthesia, they are known to produce very good sedation. That is what we require. And they also have muscle relaxation property. Muscle relaxation property, but at high dose, they can decrease the blood pressure. And they have no analgesic property. No analgesia. They don't decrease the pain, but they are very good drugs causing sedation, muscle relaxation. They can lower the BP at high dose. But when you give them still higher dose, they can suppress the breathing, respiration, the cardiovascular system can get depressed, BP may fall. So that is the use of midazolam, lorazepam, diazepam, and they are also used as pre-anesthetic medication. They cause anterograde amnesia, sedation, muscle relaxation, decrease the BP, and they don't have analgesic effect. Do they cause nausea and vomiting? No, they don't cause, because we use these drugs to treat nausea and vomiting. So they don't cause. Then moving on to the next drug, that is called propofol. Now when you enter the OT, how do you identify the propofol is being put? If you see the bottle looks like milky white. So it is a milky white powder. So the bottle looks white in color because the propofol is milky white powder. It is a derivative of phencyclidine. It is a phencyclidine derivative. Okay. Next important, it contains soya bean oil and lecithin. Since it contains lecithin, some are allergic to egg proteins. In that, lecithin is one. So it is contraindicated in patients who have egg allergy. So please ask the history before giving this. Propofol, what are the uses? A beautiful drug for anesthesia. Number one, it is used for starting induction and maintenance of anesthesia. Now it is one of the drugs which is preferred for daycare surgery. Daycare surgery. It is also used in intravenous regional anesthesia. Number 4, it is also used to cause sedation in ICU. So most of your questions is it is used in daycare surgery. But it has some speciality. What are the specialties? The drug has euphoric effect. So the feel good factor to the patient. The reason is it's a phencyclidine derivative. So they will feel a good effect. And they are potent antiemetic. So you know that most of the patients after anesthesia is given, when they are put to post-operative ward, they will have nausea and vomiting. And this drug has very good antiemetic property, and also it has a very good antipruritic property. So very, very important. The name is called propofol. So these are the specialties of propofol. A milky white powder, and it's a phencyclidine derivative used for daycare surgery. The next drug The next drug what we are going to discuss, not used nowadays, it is called etomidate. Etomidate has shown to inhibit steroid synthesis, corticosteroid synthesis. So it can cause adrenal suppression by inhibiting steroid synthesis. The next drug is by the name ketamine. Ketamine produces a special type of anesthesia, and that is called dissociative anesthesia. So patient will feel that as if though he has been dissociated from the body. And the specialty of dissociative anesthesia is patient will be having very good sedation and amnesia, he will forget these things, and patient will be immobile. So I think you have seen in the movies, from the body the soul will get up and go. So like that he will be immobile, and anything is happening he is not able to respond. So it is like dissociation from one's own body. So it's like dissociative anesthesia is done by ketamine. Very, very good. Now remember, ketamine is a drug which can increase sympathetic activity, which increases sympathetic surge. So since it increases sympathetic activity, it increases all the pressures. It increases BP, it increases cardiac output, it also increases intracranial pressure. Since it increases BP and cardiac output, can you tell me which patient should we use it? Obviously, if the patient is preferred in, if a patient has hypotension, or if a patient is having shock. Since it increases BP, don't give it in a patient with contraindicated in hypertensive emergencies. So if there is hypertension emergency, don't give the drug. The drug name is ketamine. Since it is also going to increase the intracranial pressure, it is contraindicated in head injury patients. Head injury, when the head injury occurs, the bleeding occurs, the pressure inside increases, and if I use it, it will worsen that. So contraindicated in head injury. And remember, it also increases intraocular pressure. So remember, ketamine increases all the pressures. Now since ketamine produces dissociative anesthesia, it has known to produce hallucination. So patients will have hallucinations. So once the anesthesia is over, when they come out, they have confusion, and that is called emergence delirium. So patient will be confused after this. So contraindicated in hypertension, emergency, head injury. What are the other cardiac conditions we should not use it? It is not used in stroke patient because it increases BP. Not used in ISD patients. So these are all very, very important. So remember, dissociative anesthesia, increase in sympathetic activity, hallucination, all these are important. But let me give a mnemonic for this, so you can get all the points here. Now ketamine, K for it is preferred in kids. It is preferred in kids. E for it will produce emergence delirium. So once they come out of the anesthesia, they will have hallucinations, they will have dreams and all those things. Then T for the action of this ketamine is thalamocortical junction. So that is a place of action, and because of this, it produces dissociation. So thalamus is the sensory area where we get a sensory output. So the drug affect there, and there is dissociation from one's own body. Now A for it's a very good analgesic, beautiful analgesic drug is ketamine. And M for meals. Sir, what do you mean by meals? Many a times what happens, patient has eaten the food, suddenly he had some accident, and suddenly he had some hernia which got strangulated, and you have to operate. That time, even in full stomach patient you can give it. So can be given in full stomach. Full stomach. Then I for it increases all pressure. Increases all pressure. So the advantage of increasing the pressure is you can use it in hypotension and shock. But the disadvantage is contraindicated head injury. It is contraindicated hypertensive emergencies and stroke and ischemic heart diseases. Now, N for the drug has a mechanism, it's an NMDA antagonist. E for excellent, it's one of the excellent anesthetic in asthma patients. So it's a bronchodilator. Sir, how it is a bronchodilator? Because it increases sympathetic. And what is sympathetic? Norelin. What does norelin? Norelin and adrenaline act on beta 2 receptor. Mainly the adrenaline acts on beta 2 receptor and causes bronchodilation. So by increasing sympathetic activity, you will see bronchodilation. So these are the specialties of ketamine. So ketamine is very important for your exams. So that is about the drug ketamine. Let us move on to another drug. They are called opioids. So opioid role in anesthesia is to produce analgesia because most of the anesthetics, they don't have analgesic property. So we have to supplement them. So the opioids that are used are called as synthetic opioids. Synthetic opioids are used for general anesthesia. What are these? The name is called fentanyl. Now, what is the advantage of fentanyl? It is very, very potent than morphine. It is around 100 times potent than morphine. Meaning is you can use it at very low dose, no problem. Then we have a drug by the name sufentanil. The name is called sufentanil. Sufentanil, if you see this, it is more than 1000 times potent than morphine. And it is highly plasma protein bound. Since it is highly plasma protein bound, the drug has long duration of action. So it is longer acting, sufentanil. One more drug, the name is called remifentanil. Remifentanil, remember, it is metabolized by plasma esterase. Metabolized by plasma esterase. So remember, any drug metabolized by esterases are very, very short acting. So the drug is very, very short acting. Since the drug is very short acting, the drug can be preferred in daycare surgery. The duration of action is very short, so we can prefer in daycare surgery. So recently this question was asked, which of the following fentanyl drugs are very short acting? It is remifentanil. One more is all fentanyl. So remember, all of them end with fentanyl, fentanyl, fentanyl. Clear? So all fentanyl is used for TIVA. So what is TIVA for? Total intravenous anesthesia. We are not giving any inhaled here. We are giving totally intravenous anesthesia. There we use all fentanyl. Now all these drugs, when we use, there is one common problem. They all cause muscle rigidity. They can cause muscle rigidity, and the main muscle effect are the chest wall muscles. So patient will have post-operative chest wall rigidity, and we call it as the wooden chest syndrome. We call it as wooden chest syndrome. That is a major problem with these synthetic opioids when we use it in anesthesia. So post-operative muscle rigidity is by opioids. Post-operative muscle soreness is by succinylcholine, because succinyl causes fasciculation. Succinylcholine causes fasciculation. So that is about the synthetic opioids. Okay, so we are done with the intravenous agents, benzodiazepines. Then we discussed the ketamine, then opioids, then thiopentone, etomidate, then propofol. Now let us come back. What we did is we took the example of patient undergoing hernia surgery. So what we did is we gave the pre-anesthetic medications pre-anesthetic medication. Then the induction was done. Usually induction is done by the IV drugs, and then we maintained it. Maintenance usually done by inhalation agents. Usually it can be done by IV also, usually. And during maintenance the surgery is done. Now once the surgery is done, then the anesthetist will stop the anesthetic. So once he stops the anesthesia, patient will go for recovery. Patient has to go for recovery. Next. Now what happens during recovery? Let us discuss that. Now when we use the anesthesia, most of the anesthetics where we use, they will not have all the properties. What are the properties we require during anesthesia? Muscle relaxation, analgesia, sedation, and consciousness. So not every anesthetic have this property, so we have to give something called balanced anesthesia. So what do you mean by balanced anesthesia? The anesthesia should have very good anesthetic effect. Patient should have very good analgesic effect during surgery. They should have muscle relaxation. And these are the three important aspects what we mean by balanced anesthesia. So patient should have unconsciousness, sedation, pain should be relieved, and the muscle should be relaxed. So that's the reason what we do is we give general anesthesia, drugs. Along with that, for pain we add opioids. For muscle relaxant we give the peripheral skeletal muscle relaxants. For example, the skeletal muscle relaxants end with either curium or they end with curonium. Now once you stop the anesthesia, the patient has to recover. Now the effect of general anesthesia will still remain. It depends on the oil gas coefficient. So it depends on oil gas coefficient. I told you it is inversely proportional to recovery. Now the patient will recover when you stop it. But how do you reverse opioid? You will reverse opioid only if the patient develops respiratory depression. If the patient develops respiratory depression, then the drug will be naloxone, otherwise not required. If you give an opioid higher dose, patient develops respiratory depression, you can reverse it by giving naloxone. Suppose you have given muscle relaxant, and how do you reverse it? How do you reverse them? The reversal can be done with neostigmine or a drug called pyridostigmine. So this will help in faster reversal. So we use neostigmine or pyridostigmine for that. Now what happens after anesthesia? Many a times there is a chance that patient may develop post-operative paralytic ileus and post-operative urine retention. Post-operative paralytic ileus or urine retention. How do you overcome that? For that also we can give neostigmine or pyridostigmine, or we can use one more drug and the name is bethanacol. Now one more complication post-operatively that can happen, and post-operative shivering. And in the books the drug of choice given is pethidine. So these are the options when the patient recovers after anesthesia, and this is how we reverse it. So this is about general anesthesia. So general anesthesia, I took an example of hernia surgery. I told you how actually it is being done. We give pre-anesthetic medication. We have certain inducing drugs, maintenance drug. Then surgery is done during maintenance period. Surgery is over, anesthesia is stopped, patient will recover. So anesthetic agents are two types. Either we give by inhalation or by IV. Inhalation, we have gas and liquids, and they are given through special devices, the Boyle's machine, and they have different pressures. So we have the cylinder color and pin index so that they match. There should not be any mistake. because the pressures are different in different cylinders. So once they enter, the anesthetics go inside, come to the circulation, then enter the brain. There is a coefficient for blood gas. So that is called blood gas coefficient. That will tell us induction. After the action is over, the drug has to come out and eliminate. So that depends on oil gas coefficient. And that will tell us recovery. Minimum alveolar concentration is the minimum concentration of anesthetic to immobilize 50% of patient, and that will tell us potency. So they are inversely proportional. Then we discussed the nitrous oxide, halothane. Then we discussed the fluorine drugs, enfluorine, sevoflurane, desflurane, isoflurane, and xenon. And what are the common properties of them? IV we discussed thiopentone, propofol, ketamine, very much important. And once the anesthesia is over, there are post-operative problems. You can reverse the muscle relaxation by using certain drugs, neostigmine, predostigmine. Opioid overdose can be managed with naloxone. And paralytic ileus and urine retention can be managed with the same drug, pyridoxine, same drugs, pyridostigmine and neostigmine. One more drug is methanacol. Post-operative shivering, we can use pethidine. So that is about general anesthesia in brief. Thank you all.